Good evening, everyone. Here Imran Abbas. Again, we are live. I am from Dubai and Professor Abdelrahman Nimeri from USA. It is really great honor for me to interview such a great and prestigious figure. You all know better than me, so there is no need to introduction of professor. I remember, so I have started bariatric surgery in 2005. So at that time, so definitely still I am student of bariatric surgery. And at that time, so professor was our inspiration and definite in different international meetings, different international programs, always. So professor lead bariatric surgery and he has a crucial role to promote and also especially this obesity science, not only bariatric surgery. Sir, it is great honor for mine and also for all of our viewers. We have started this series of interviews. So as you know, so we have finished series interview of MGB, OAGB. Then we have started safe sleep gastrectomy because unfortunately our new surgeons, youngsters, they think, okay, there is no issue. There are some staplers and we will staple and sleep is so much easier like this. So this was the main thing that I have started this series of interview. And so because one thing that is the most important message from someone who is expert of sleep, who knows sleep, then it will be more effective. Because if we compare with a webinar, you know better than me, in webinar we have 5 to 10 minutes. So we cannot convey message. Interview, so this is just in light mood. You can share your personal experience. And the main thing, convey the message, safe sleep gastrectomy. Sir, so much thanks. Really, it is a great honor for me. Sir, over to you, please.
Sir, thank you, Imran. It's really my pleasure and privilege. Oh, am I muted? Can you hear me?
Yeah, I can hear you, sir.
It does not show here that I'm muted. Okay. Yeah, it's thank you, Imran. It's really my pleasure and privilege to join you. So I think everything starts with patient selection. So sleep gastrectomy is a good option for certain patients, and we try to offer sleep gastrectomy to someone who has a low BMI with the expectation that it's going to be a primary procedure, or someone who either has high BMI and has an expectation that it will be a stage to maybe a duodenal switch or a SATI, or someone who's a high-risk patient. It's also a good option for someone with Crohn's disease or a patient with previous multiple abdominal surgeries. So selecting which patient should have a sleeve gastrectomy is the most important thing first. So if someone has reflux, sleeve gastrectomy is probably not their best operation. Patients with BMI approaching 50 or more than 50, also sleeve gastrectomy is not their best operation. Or in general, someone with a previous band sleeve gastrectomy or previous VBG, they're not their best operation. So everything starts with patient selection.
Sir, so much, because you know better than me, so we have some repeated questions, because at the end in December we will have a sum up session of this safe sleeve gastrectomy. So most of us we know about you, but because this is a protocol of interview, sir, your brief introduction.
Oh, sure. Abdelrahman Nimeri. I'm a bariatric surgeon in Charlotte, in North Carolina. The section chief of Atrium Health Weight Management Bariatric Surgery Department and the program director of the fellowship program. And currently I serve as the secretary and treasurer of IFSO since 2019.
Excellent, excellent, sir. I know, sir. Also, we know about your journey of bariatric surgery.
Sure. I would not say that I have chosen bariatric surgery to do, and I think this is an important message and lesson to residents and medical students. So you need to do what comes your way. So after finishing residency in Cleveland, I chose a fellowship that did not have a lot of bariatric surgery in it. And I learned mostly other disciplines. Bariatric surgery was probably 20% of the fellowship. Most of the fellowship was foregut surgery, solid organ, things like that. And like many young surgeons, I was heavily interested in learning techniques. And it just so happened, even the job I took, my first job in Fresno at UCSF, was not a bariatric surgery job, but it was in the same city and at the same hospital where Kelvin Higa and Keith Boone practiced, and I ended up working with them. So at the end of the day, you need to recognize that you might not choose a certain specialty. It might sometimes come across you. So I learned most of what I know today about bariatric surgery when I joined Kelvin Higa and Keith Boone as their junior partner. So sometimes, as I said, the specialty might choose you rather than you choosing the specialty.
Yeah, definite, sir. And I know especially your participation in IFSO and many organization. I remember when your active presentation in here in Gulf countries, in Middle East, in Abu Dhabi, and everywhere. So much, sir. It is great honor, sir. When and why you have started sleeve gastrectomy, especially sleeve?
Sure. So I was when I moved from Fresno to Abu Dhabi, sleeve gastrectomy was not a common operation. This was in end of 2008, beginning of 2009. And at the time, sleeve gastrectomy was not common. We used to do primarily Roux-en-Y gastric bypass in the US and gastric bands and revisional surgery. Even duodenal switch was not as common. Very few places performed it. Then when I moved to Abu Dhabi, I saw an article from the Cleveland Clinic publishing 5-year retrospective review of sleeve gastrectomy outcomes. And I became interested in learning about it. So I actually went back to the US and attended a course by Michel Gagne, a course that was sponsored by J&J. And I learned the technique in that course. And then I remember in November of 2009, we had a bariatric surgery course in Abu Dhabi, and we invited Phil Shower, and that's where we did our first sleeve gastrectomy at SKMC. And I think the important message is that if you're going to learn about a new procedure, it has to have 5-year outcomes at least.
Yeah.
And you need to learn the technicalities first in a dry lab about the procedure. And then the first time you do it, you need to have someone experienced with you in the room. You cannot start something new on your own. And even if you work in private practice alone, you can find, a more senior surgeon, someone that can help you. It's important when you start something new that you don't start on your own, because you owe it to the patients.
Yeah, sure, sir. Definite, sir. Now more than 1 decade. So you are practicing sleeve gastrectomy, sir. Which percentage? So what percentage of your bariatric surgery belongs to sleeve gastrectomy now in 2021?
35 to 40%.
35 to 40%. So during this journey of sleeve gastrectomy, definite now more than 1 decade. So you have started in 2008-9 sleeve gastrectomy, and progressively you see many. So definite, so complications, side effects, so long time, short time. And every surgeon, so this is the evolution of our practice. So we also, yes, we learn from others, from mentors. Also, we learn from ourselves. So can you, sir, highlight so that tips and tricks are the points that you have changed progressively for better results?
Sure, sure. I think when you do a sleeve gastrectomy, first port placement is important, not only sleeve gastrectomy, but in the entirety of operating on patients with obesity. So where you place your ports can make your case more difficult or easier. Then, in the initial part of taking down the short gastrics, you need to be careful while working near the spleen, obviously, because you could not only have bleeding from that area, but if you're not careful, you could injure the splenic vessels, which could be a more catastrophic complication. What's important is if you get into bleeding, you need to be able to tamponade out the bleeding to make an assessment. And you tamponade out the bleeding by placing 4x4s. And I think what's important is, let's say you've decided you're going to open someone because you cannot control the bleeding. You cannot open the person while the patient is hemorrhaging. You need to tamponade out the bleeding with a 4x4, grab it from a lateral port, and then open the abdomen. Most important thing is to have a thoughtful process about what you're doing next. So then performing the sleeve itself, you want to make sure, as everybody knows, that you don't come too close to the incisura, so as not to have a stricture there. You want to make sure you don't twist the sleeve while you're stapling by too much traction. And the jury is still out whether if you remove more antrum or leave more antrum, it's better for outcomes. However, most patients I see for weight regain tend to have a large antrum. I'm not sure if that's the cause or it's just an association. And then finally, you need to make sure you're not too close to the GE junction as to not have a leak in that area, because the staple line, if it's under tension, you can have a leak. Then the next step is to decide what are you going to do about the staple line itself. I believe leaving the staple line alone has a high bleeding rate and higher complication rate. So I've chosen from the first day to oversew the entire staple line in a Lambert fashion with absorbable material, use PDS, and I've been happy with that. You could choose other things. You could choose staple line reinforcement, it's just more expensive. You could choose placing clips. It can cause you problems if you come to revise patients, because if you staple across a clip, it will be a problem. But you just have to choose what are you going to do about the staple line.
Sir, excellent. Sir, have you any video? Are you ready to share any video of your technique, or we can go ahead with questions?
I don't have a video prepared, sorry, but I'll be happy to answer any more questions.
Sure, sir. Sir, what is your protocol of pre-op endoscopy and H. pylori eradication in sleeve gastrectomy cases?
Sure. So in general, we only do preoperative endoscopy for someone with symptoms. Symptoms meaning either reflux or epigastric pain or family history of stomach cancer. And the reason is because insurance companies in the US do not cover endoscopy in someone without symptoms. However, if insurance companies do cover it, I think it's reasonable to do endoscopy. And then in general, if someone has reflux and they want to have a sleeve gastrectomy, I usually will do a Bravo study at the same time, because if the Bravo study shows that they have significant reflux, then I would not recommend that they have sleeve gastrectomy. In terms of H. pylori, if we scope someone and they have symptoms like epigastric pain or symptoms of H. pylori, we biopsy and try to eradicate it. Because we don't live in a we don't always eradicate H. pylori. I used to do the same thing when I was in Abu Dhabi. And we did not check for H. pylori on every patient. And for 9 years, we had no problems in both sleeve and bypass.
Sir, excellent. Sir, regarding post-op, because you know better than me, when we are in different international meetings, nowadays the main issue is GERD after sleeve gastrectomy and different debates, so surveillance of endoscopy and post-op. What is your opinion, sir?
So I go back to patient selection. There was a very important study from Switzerland that looked at patients who had sleeve gastrectomy, and before surgery, they had a symptom questionnaire and they had pH and manometry. Many patients who develop de novo GERD have silent GERD before surgery. So that's why you need to be very particular about looking out for someone with reflux disease. And you need to recognize that LA grade A and B esophagitis do not correlate with the presence of positive pH testing. However, LA grade C, D, or Barrett's do. So if someone has LA grade A or B esophagitis, they could still have objective evidence of reflux on a pH study. And post-op reflux could be because the patient had pre-op reflux that is just getting worse. So patient selection, again, is important. Currently in the US, we cannot afford to perform endoscopy on patients every year. And even when I was in Abu Dhabi, even though it was a nationalized health system, we did not perform endoscopy on patients every year. I mean, it is from the recommendation of both IFSO and ASMBS that surveillance endoscopy at some point, maybe 3-5 years after sleeve gastrectomy, might be necessary. However, for sure, patients with symptoms should have surveillance. We know that Barrett's could be asymptomatic, but at least patient with symptoms should have surveillance endoscopy.
Sir, thank you. Sir, regarding this, because already in your earlier, so you have mentioned some relative and absolute contraindication. So we want to hear again. So in your opinion, what is relative and absolute contraindication of sleeve gastrectomy?
So someone with severe reflux, either stage C or D esophagitis, Barrett's, is probably better served with a Roux-en-Y gastric bypass, unless there is a specific reason to do sleeve gastrectomy. I prefer to do sleeve gastrectomy in higher risk patients. So if someone has esophagitis, but they're a high risk patient, I will still do a sleeve gastrectomy. There are very few absolute contraindications. One of them would be Barrett's, because Barrett's could get better with Roux-en-Y gastric bypass. At least 30% of Barrett's does. So maybe Barrett's is one. There is some literature from Europe, especially from Germany, to say that one of the reasons sleeve gastrectomy patients are more prone to portal mesenteric thrombosis is that you take down the short gastric, so you elevate the portal venous pressure. It still remains to be seen. So I've heard authors in Germany saying that in patients with liver disease, they don't perform sleeve. I still, if someone is high risk and they have liver disease and they're a surgical candidate, I'll still do a sleeve gastrectomy. Obviously, if someone has child C, they're not a surgical candidate anyway, including sleeve. But there are very few contraindications for sleeve gastrectomy. It's a very versatile operation, and I think the presence of sleeve has made it easier for us to be able to treat higher risk patients, to able to stage patients with very high BMI if you have intraoperative difficulty that we didn't have before the sleeve gastrectomy was present.
Sir, thank you, sir. So because one of the issue is definite is Nepheld, NASH, and cirrhosis in obese people. You already have mentioned, so in child till in earlier stages, we can do a sleeve gastrectomy. So have you any experience of improvement in liver condition and after sleeve gastrectomy?
In general, after bariatric surgery, patients with a non-alcoholic fatty liver disease and NASH, they improve. Not only sleeve gastrectomy, but also gastric bypass. What's important to mention is that if someone has liver dysfunction, you should not perform one anastomosis gastric bypass or biliopancreatic diversion or duodenal switch. because the risk of deterioration of their liver functions are worse. So, I mean, you have to look at the patient as a whole. So for instance, I'll give you another example. So kidney stones. Patients with significant kidney stones are better served with sleeve gastrectomy rather than gastric bypass. So the patient is not only BMI or reflux or previous surgery. Many things also are important in the decision making.
Sir, thank you. Sir, sometimes because we have hiatal hernia, but hiatal hernia size is not larger, sir, just 3-4 centimeter, not so bigger than 5 centimeter. And you prefer to do sleeve gastrectomy in such a case, and also you prefer to do hiatoplasty?
Sure. So most of these patients also have reflux with them. So the assessment will depend on the assessment of reflux. So let's say I see someone in my office, they have a small hiatal hernia. They're interested in sleeve gastrectomy. Rather than just doing an endoscopy, I will do an endoscopy with Bravo capsule study. And if the Bravo capsule study shows that they don't have significant reflux, their DMESTR is below 14 and so forth, then if that's the patient's preference, I'll do a hiatal hernia repair and a sleeve gastrectomy. Sure.
Sure, definite. Sir, in your now more than 1 decade, definite, you are facing your personal cases of sleeve gastrectomy as well as referral cases in different, so you are in tertiary hospitals. So have you faced, especially for your own patients, this intractable GERD after sleeve gastrectomy, and also you did Roux-en-Y or any other surgical intervention in such a case?
Sure. I think having severe reflux after sleeve gastrectomy is quite common. If it wasn't the most common revision or reason, it may be first or second. And for most of these patients, we convert them to Roux-en-Y gastric bypass, even if their BMI is below 25, and they still do extremely well. But the most important thing is before converting them is documenting that they have reflux. So an endoscopy that shows grade A or B esophagitis is not enough. You need to either have an endoscopy that shows grade C or D esophagitis or Barrett's, or you need to have a capsule study. And sometimes if the person has reflux that doesn't get better with PIs, you might suspect alkaline reflux and you need to do an impedance test, so a nasal probe pH study, 24-hour nasal probe, because that can show you alkaline reflux. But these patients do extremely well with the and if your BMI is low, they don't significant.
Sorry, sir, there was.
Can you hear me now?
Yeah, sir, I can hear you. There were some connection issues. Sir, my question, because this is the debate that,
okay, good.
That most of our youngsters, and personally myself, we want to know about this. Sometimes, so patients' symptoms is GERD symptoms. There is no clinical findings in upper endoscopy. There is no esophagitis, but really patient is suffering. So no response to PPI, no response to other medication, diet, everything. So what we do? So in such a situation, so we must just convert the patient to Roux-en-Y gastric bypass?
No, you first need to do to see alkaline reflux. They will have might not have that on an endoscopy, and their pH Bravo test might not be positive. But if you document presence of reflux, you should not convert by converting the patient to Roux-en-Y gastric bypass unless you have documentation. You put them at risk without a benefit.
Sir, I think there is some internet issue. Can you hear me?
I can hear you.
Yeah. So definite, sir. So as you have mentioned, so first of all, you must rule out any alkaline reflux, then we can decide. So if there is no alkaline reflux, nothing but patient,
I would not offer them surgery.
it will not resolve. If we will do Roux-en-Y again, patient complaint will say.
So I mean, right? We do not offer surgery for symptomatic relief without objective findings. You have to have objective findings on either endoscopy, pH study, manometry. Someone's main problem is dysphagia. You might need to do esophageal manometry. There is a new condition that's described now called POSID, described by the group from Mayo Clinic. It's called post-obesity surgery esophageal dysfunction. And patients, both after sleeve and Roux-en-Y gastric bypass, could develop dysphagia that looks on a manometry very similar to achalasia, but the reason is esophageal dysfunction from the obesity surgery itself.
So one of, sir, this complication we can ask of sleeve gastrectomy, pseudoachalasia, definite due to high pressure. Mostly it is after gastric bending, not sleeve, but sometime we face such a situation. So what we do in such a situation? Have you faced?
Yeah, we've seen that many patients present with dysphagia, and we do esophageal manometry, and it looks like achalasia. What's important is to differentiate whether the person has achalasia or has a stricter sleeve or a twist from a sleeve. Having an experienced gastroenterologist who can do an endo flip for you might help, but it's important to differentiate. And I've had patients who, even had a peroral endoscopic myotomy for achalasia, like picture, and they did not improve after. So patients are difficult to manage. They're complicated. You need an experienced gastroenterologist, and you need to make sure that you identify exactly where the problem before offering them any solutions.
Sir, we know, because now because we are also live on Facebook, and definite hundreds of surgeons, they watching our interview. I need a message from your side, especially technical point, because this topic is safe sleeve gastrectomy. Definite in future, because we have next year we will follow Roux-en-Y, then we will follow low BMI. In 2023 we will follow redo. Then we will also discuss about complication and how we deal. But now our topic is safe sleeve gastrectomy. We want to hear from your side tips and tricks, what new surgeon must do to decrease the chance of GERD after a sleeve gastrectomy.
Number one thing is, as I said earlier, patient selection. Don't offer sleeve gastrectomy to someone with reflux without objectively testing them with endoscopy and or pH testing. The second is, at the time of surgery, if the person has a hiatal hernia, you need to fix it. Don't do this, make the sleeve too tight. Weight loss doesn't happen because the sleeve is too tight. Sleeve gastrectomy is a metabolic operation similar to bypass and other metabolic operations, and most of the effects happen because of distal delivery of nutrients. So you don't need to make the sleeve too tight. Watch for causing a stenosis or angulation at the incisura, because that could be the cause of your reflux symptoms.
Sir, thank you, sir. Sir, one of the nightmare after sleeve gastrectomy is leak. So maybe personally you have faced, or definitely you have dealt with your colleagues or referral cases. So what we do that points, then there will be less chance of leak after sleeve gastrectomy. So you have mentioned, so you enforce and you stitch or imbricate your staple line or any other step.
Sure. So one important thing is to make sure that you don't go too close to the incisura as to not cause a stricture, because that can be one of the reasons for a leak. In my own experience, making sure that when you're using the ultrasonic dissector or the bipolar device, that you don't aggressively stay too close to the stomach. You could injure the stomach doing that. You don't staple too close to the GE junction. And then if you can, imbricate the stomach staple line near the GE junction with Lambert suturing. So serosa to serosa. These are the things that we do, and then don't make the sleeve too tight.
Sir, what is your opinion about omentopexy?
I mean, you could do it, but at least the group from New York, Alphonse Palm's group, has done a randomized study comparing sleeve gastrectomy with or without omentopexy and found no difference. You could do it. It depends on your experience.
Sir, because this is a question is from Dr. Mejda Ismail, I think from Iraq. Same question. So to prevent twisting of stomach, did you fix stomach to omentum or not? Or you have another technique?
I don't typically fix the stomach to anything. Once we oversaw the staple line, that's all what we do. And we've not had problems with, strictures or twisting.
Yeah. Sir, regarding, because again, there are some basic questions. Definitely we have, because the main, our viewers are also newcomers and they want to learn about sleeve. So we also interested to know about bougie size in a sleeve, and also this your first stapler from pylorus. So these 2 points, if possible, please highlight.
Sure. So as I said earlier, there's no clear literature whether if you staple 2 centimeters versus 6 centimeters, which one is better. We go about 3 to 4 centimeters from the pylorus, and typically we use a endoscope. You could use about a 36 or a 40 French bougie, and we do not hug completely to it because we oversaw the staple line.
Excellent, sir. So I think this is very important regarding portal vein thrombosis. Definitely, you have mentioned. So how can we prevent this portal vein thrombosis? Because one of the really disaster after a sleeve gastrectomy is portal vein thrombosis.
Sure. So portal vein thrombosis is a type of venous thromboembolism. So you need to risk assess every patient for venous thromboembolism, and you need to recognize few facts about venous thromboembolism. Pulmonary embolism is the one of the top 2 or the number 1 cause of death after bariatric surgery. If a patient develops a pulmonary embolism, their mortality at 1 year after surgery more than doubles. And even though these complications are rare, they could be catastrophic. So what's important is to also know that 80% of VTEs happen after discharge from the hospital. So you need to risk assess every patient for VTE. We use the Caprini risk assessment model. So age makes a difference, whether the person is 35 versus 45 versus 68 versus 75 makes a difference. Each one of them is a higher risk as you get older. BMI makes also a difference. BMI of 40 versus 50 versus 60. And previous history of VTE. You need to ask every patient if they had a venous thromboembolism in the past, or if their first degree relatives, parents, siblings, children have had a VTE in the past. And then what we do is we use this Caprini risk assessment model, and anybody with a Caprini score of 4 gets prophylaxis only in the hospital. We use Lovenox because it's been shown to be better than sub-Q heparin. And then anybody with a score more than 4, 5 or more gets Lovenox for 2 weeks after surgery.
Sir, excellent. Sir, one of the things that if you remember in, I think If so, London, also Cleveland Clinic, they present an article and also a formula and calculator for selecting the patients. When this score was high, patient is CHF, patient has different issues, age, they prefer to do sleeve gastrectomy, not malabsorptive surgery. So there is no chance of this portal vein thrombosis in such a case?
It's not that there is no chance. It's just that in higher risk patients, it's preferred to do sleeve gastrectomy. And then you prophylax these patients against VTE, whether it's DVT, pulmonary embolism, or portal vein thrombosis. So higher risk patients are preferred to have a lower risk operation like sleeve gastrectomy.
Definite, sir. Sir, weight regain after sleeve gastrectomy, that is also another challenge and also one of the concern of surgeon as well as patients. So which percentage of your patients facing weight regain?
I don't know a percentage. However, I know that the most important thing to look at is what was the person's BMI before surgery. If you do a sleeve gastrectomy on someone with a BMI of 51, they will have a significant amount of weight remaining 5 years from surgery. So again, I go back to patient selection. However, in general, at least 30–40% of patients after sleeve gastrectomy will need something done because of weight regain, especially if their BMI is above 50.
Yeah. So regarding GAID also, again, this is the question. So which percentage, about which percentage of, yes, your patient selection, everything is okay, fine. But again, some percentage of your patients are suffering with GAID. Have you any number, any data?
So probably 20–40% of patients will develop reflux after sleeve gastrectomy, and at least 1–5% of them will need something done surgically.
Sir, if we compare, so when you have started sleeve gastrectomy, definite because you were with the Professor Higa and he's the pioneer, one of the pioneer of Roux-en-Y gastric bypass, and definite you are also well known for Roux-en-Y. So during this journey of bariatric surgery, so this sleeve is same like 30–40% as earlier, or no, you have decreased your practice of sleeve?
It has not changed much because we use it primarily for certain indications. So the indications has not changed.
So patient selection was very important and you are happy, your patients are happy also after sleeve, and there was no issue.
Right.
Sir, I cannot see you, sir. I think your video has been, so please, sorry, thank you, sir. Sir, regarding endoscopic role, so you know, nowadays, so they ask endoscopic sleeve or endoscopic gastroplasty. What's your opinion, sir?
I have no experience with endoscopic sleeve gastroplasty. I don't do it, so I'm not sure.
No opinion and no comment regarding this. Because now, especially for low BMI patients, so patients low BMI and they don't like to do any surgical intervention, and they are going for, and definite for complications, yes, you know better than me, maybe endoscopic role is very dominant, but in initial surgery, you have no comment according to this.
Yes. I don't have enough experience to comment.
Sir, how? Because now you have lot of experience, and now about 2 decades you are involved, especially with bariatric surgery, in different types of bariatric surgery, and also you have leadership qualities, and you are leading many these societies. So how you see the future of sleeve gastrectomy?
I think it will become done less, in my opinion. It's not going to go away similar to gastric banding because, as I said, there are certain patients where sleeve gastrectomy is the perfect indication. Higher risk patients, lower risk patients without reflux or diabetes, patients with Crohn's disease, patients with previous surgeries. For all those patients, sleeve gastrectomy is still an excellent option. However, I don't think it will be as common as that is done today, in my opinion.
Sir, I have personally, I have no experience. According to this question, patient with symptomatic reflux, what are they doing? Some of surgeons, because I see some videos, fundoplication and sleeve gastrectomy.
Sure. This is described by Professor Noka. I don't have experience with it, but according to surgeons who do it, it's effective. In my humble opinion, if someone has reflux and they come to see me and I document they have reflux, I offer them Roux-en-Y gastric bypass. I just don't have any experience with the Nissen sleeve, so maybe it works. I don't have experience with it.
With this, regarding adolescents, sir, also you prefer sleeve gastrectomy?
So we have an adolescent program, and we treat the adolescents very similar to the adults. So higher BMI, they have a Roux-en-Y gastric bypass. Adolescents with reflux or diabetes have a Roux-en-Y gastric bypass. Lower BMI, we offer them sleeve gastrectomy. It's no different than adults. It's exactly the same.
Same thing. And regarding this metabolic impact of sleeve gastrectomy, already you have mentioned, so this is also metabolic surgery. So definitely we can also prefer in a patient with diabetes. So in patients with obese patient type 1, because the adolescent definitely they are type 1. So also improve the diabetes and then dose will be less. So yes, there is not, we cannot ask patient will take insulin, but less dose.
Right. In general, when you offer someone surgery for type 1 diabetes, the primary indication is not the type 1 diabetes, it's the obesity itself. So you're offering, their BMI has to be over 35, and the benefit they get is primarily from, probably losing weight, improving their insulin resistance a little bit, as you stated. It's different for type 2 diabetes than type 1 diabetes for sure.
Sir, really, thank you so much. Thanks. And it was really very practical and, in my opinion, very fruitful interview. Sir, any message for our youngsters, because they are now just going to start sleeve gastrectomy? Please, sir.
Sure. I think the most important message is to recognize that obesity is a disease. Our patients suffer a lot from the stigma of the disease. We as bariatric surgeons need to not contribute to this and to educate the patients and their families. And many times I see patients coming to the office and they're struggling with their decision to have surgery. And our job is to show them the health risks of obesity and try to debunk the stigma and the myth associated with it. And that's our most important job as bariatric surgeons.
Sir, so much thanks. And personally, I have learned a lot. And so much thanks our viewers, because still now you are with us, especially from India. I can see, so now in India, midnight, also this area of Asia, many of our viewers are live with us. So much thanks. And so this program is with your support. When you support us, so encourage us. So again, it is a very encouragement for myself, for our group, for our team. And it was great opportunity for all of us. So Professor was live with us. Professor, definitely we need your support and guidance. We will continue this series of safe sleeve gastrectomy interview till December 2021. In December 20, every Tuesday, this time 10 p.m. Next week also, we will have Professor Safwan from Abu Dhabi. And again, we will continue our series of this interview. And my viewers, we need your support. If you have any question, you can personally ask this question and also ask in comment, and Professor will be available. Sir, so much thanks and really appreciable. And again, I need your support, your guidance in future for Roux-en-Y gastric bypass, redo surgeries, and low BMI procedures. Thank you, sir. Have a nice time.
My pleasure. Take care. Bye-bye.
Thank you. Thank you, sir.